Good morning, everybody. I'd like to thank the organizers for asking me to come and speak to you today. My topic is going to be to illustrate the role of dynamic contrast enhancement for prostate cancer diagnosis in practice. These are my disclosures. Let's start with a patient. You can see this is a 63-year-old physician. Has a rising PSA, currently 18 nanograms per ml. He's had one trust negative biopsy, and this is what he said to me: "I never want to see a urologist again." His wife came to me. She said, "Please find his cancer. His PSA is rising." And we did this multiparametric MRI, and we can see here anteriorly there's a large 2.2 centimeter anterior fibromuscular stromal tumor. That is positive on the T2 image. It's positive on the diffusion sequence. It's negative on the spectroscopy, and this enhancement curve, which corresponds to this ROI, would be classified as negative by most people. So the questions that arise from this case is, why is DCE MRI sometimes positive and at other times negative? And this clearly depends on the biology and the underlying vascularization of the tumor. Another question that's often asked is, should DCE MRI always be used for lesion detection? And this is a hotly contested topic, which I will discuss a little bit later on. And a slightly separate question is, should DCE MRI always be used for index lesion localization? And that really does depend on anatomical location and the post-therapy status of patients. So if you were to inject contrast medium into a patient and you were to do a T1 or a T2 experiment, you would see two different phenomena. So if you ran a T2 experiment, you would see darkening. So here, for example, you see an area of darkening, which in fact corresponds to this area of brightening on the T1 sequence. Now, you really do not need to do this sort of sequence in clinical practice, but if you were to do it, this is the kind of appearance that one would see. The T1 brightening phenomenon is the sequence that we normally use, and this is just some still images from the same patient, a low ADC value here, and you can see that there are several phases. There is the wash-in phase, there's a plateau phase, and there seems to be a wash-out phase as well. So the plateau phase, so here on this curve, represents the fact that the gadolinium, which leaks into the extracellular space, is leaking out at the same rate as it's leaking back into the venous side of the circulation. And then clearly during the washout phase, the gadolinium is going out from the extracellular space back into the vascular space, and that's what causes this washout. Now, if you were going to do a DCE MRI protocol that was PI-RADS 2 compliant, then a 3D gradient echo sequence is preferred. Due to higher signal to noise, you need some sort of fat suppression, either a FAT-SAT or a Dixon technique. You want a T1 sequence, so you want a short echo time, that's in phase, a flip angle that's large, that's to say about 30 degrees or greater, a slice thickness of about 3 millimeters. You want quite fine resolution, 2 millimeters by 2 millimeters, and you want to be able to go fast. Less than 15 seconds is recommended, but most of us do less than 7 to 10 seconds. And really the observation period doesn't need to be very long nowadays. We've taken that down to just over 2 minutes, and it just uses straightforward 0.1 millimolar kilo of gadolinium contrast agent injected at about 2 to 3 cc's per second. Now, when you perform these sequences, you will be able to evaluate the DCE MRI scans in several ways. You can do morphological descriptors of enhancement on the fat suppressed or the early subtraction images. You can look at time signal intensity curves, or you can use some sort of combination, and this is the ESUR ACR PI-RADS schema. So let me just show you the latest PI-RADS version 2 scheme, which only uses morphological descriptors. So you either evaluate the prostate and you call it negative, or you call it positive. So negative is no early enhancement or just diffuse bilateral enhancement not corresponding to a focal lesion on T2 or diffusion sequences. Or if you have a focal lesion, it's basically BPH on a T2 sequence. So that'll all be considered as negative. A positive assessment is a focal lesion that enhances early and corresponds to a suspicious finding on the T2 or diffusion sequence. So here's an example of a patient who has a tumor in the peripheral zone of the prostate gland, which you can see is quite difficult to see on the T2 sequence because of hemorrhage. You can see that on the subtraction image we are able to pull out this abnormality, which you can see here on a MIP display on this particular patient. Now you'll notice that there is some hemorrhage here in the peripheral zone. This isn't tumor infiltration, but in fact just represents blood from the truss biopsy. So that's just morphological descriptors. There are several options for evaluating the time signal intensity curve on T1 sequences. This can be qualitative. You can either use model-free indices or physiological indices. These are not really prescribed for clinical practice. For clinical practice, a lot of us still use curve shapes of signal enhancement data. And the PI-RADS version 1 used such a schema. Some of us are still using the PI-RADS version 1 score, which uses curve shapes as well as asymmetry and focalness to assign a total score, but this is no longer in the guidelines. So here's a typical example of a large tumor, this time in the transition zone on the right. Here's the diffusion sequence, here's the ADC map, and you can see that there's quite a strong wash in and a strong wash out from that region of interest, identifying that to be a cancer, which in fact turned out to be a solid 3+3 cancer in this particular instance. So the PI-RADS version 2 system has not been comprehensively validated, but the PI-RADS version 1 system has been validated. So here's a study of 129 patients in prior negative truss biopsies, and you can see that if you perform targeted biopsies in patients with a score of a DCE score of 1, then the chances of you getting a positive core are less than 5%. Similarly, if you have a PI-RADS 3, the chances of you getting a positive core of clinically significant cancers is about 20%. However, once you have a score of 4 or a score of 5, you can see that the prevalence of clinically significant disease increases from about 60% and about 80% in truss negative biopsy patients. This is similar data published last year, looking at biopsy naive patients, again showing the same phenomenon. So if you have a PI-RADS score that is negative, then you can see that the chances of you having a negative biopsy are quite high. Usually less than 20% will be positive. However, if you have a score of 4 or if you have a score of 5, then you have a 60 and about a 75 to 80% chance of having a positive core from a lesion. So what contributions can DCE MRI make to your clinical practice? There are a number of areas where it can be very useful. First of all, it can help overcome some of the artifacts that we see on diffusion imaging caused by air susceptibility and by blood from biopsies, and in this regard subtraction images are very useful. It can help explain a cause of a raised PSA, both benign and malignant, by showing you lesions that are look-at-me lesions or areas of prostatitis. So here, for example, is a patient with a raised PSA. You can see there's diffuse low signal change in the peripheral zone. On the contrast enhancement, you see no focal abnormality, but you see quite a lot of diffuse enhancement, and this was biopsy proven to represent prostatitis in the peripheral zone. There was a small lesion here anteriorly, which is not that well seen on the subtraction images, which turned out to be a Gleason 3+4 cancer, but clearly the area that was causing the raised PSA was this prostatitis and in fact mixed with Gleason 3+3 disease in the peripheral zone. Here's another look-at-me lesion. You can see there's an abnormality here in the peripheral zone of the prostate gland. It's difficult to know what this is. On the T2 sequence, you can see there is an abnormality in the diffusion sequence, so it's certainly highly cellular in this area. But if you look at the dynamic contrast enhancement, you can see there are focal areas of enhancement within this area, and this is the enhancement curve of that lesion. The ROI is this ROI over here. This is the normal peripheral zone on this side, and this is the area of diffuse change which you see here. And this heterogeneity is very classic for a possible carcinoma underlying this area, and there was a 4+3 cancer diagnosed on a targeted biopsy. This is the classical use of DCE MRI as an area of showing an area of recurrence, which in this particular instance is also positive on the diffusion sequence and difficult to call on a T2 sequence alone. The other area where I think DCE can be helpful is in characterizing an abnormality that you have seen, and this is incorporated into the PI-RADS version 2 system. So if you have a diffusion abnormality in the peripheral zone and it is a PI-RADS, it's a DWI score of 3, you can use the DCE MRI to promote that to a PI-RADS 4 if the DCE was positive. I just wanted to show you a couple of examples. So here are a couple of focal lesions in the peripheral zone of the prostate gland. Here they are on the diffusion sequences. You can see that these would be called PI-RADS 3 or PI-RADS 4, probably PI-RADS 3 because they're not really that hyperintense. On the high B value images, here they are again at the base in the peripheral zone, and in fact this is the dynamic enhancement curve. You can see no heterogeneity at all. The left and the right are exactly the same. This in fact represents prostatitis on biopsy. Here's another lesion, this time in what looks almost like the central zone of the prostate gland. So it's at the base, it's in the midline, it looks like it's invading the seminal vesicle, so it is suspicious. But on the diffusion sequence, it's a difficult lesion, not obvious. There's some artifact arising from the gas in the rectum, but clearly on the contrast enhancement we can see there's an enhancing mass washing in, washing out, and this was a Gleason 3+4 lesion. The other area where DCE makes a real contribution, I think, is in monitoring response to treatment, particularly in patients with who have been treated with anti-androgens, for example. And I just wanted to show you an example of that sort of use in active surveillance. So here's a patient seen 1 year apart, December 2011, September 2011, October 2012. Difficult to see that there is slight increased mass effect here in the peripheral zone. Here's the right side, here's the left side. On the T2, on the diffusion sequence, really no change. But if we look at the subtraction image, you can see that there is a new area of vascularization. This was biopsied, showed Gleason 3 plus 4 cancer, which at prostatectomy turned out to have Gleason 4 plus 5 plus 3 and microscopic T3A disease. So, should the DCE MRI be included in the guidelines? And this is an area of debate, and some of you will have seen this recent letter and the response from the PI-RADS committee to this letter in European urology. The argument is that DCE MRI adds cost and time. Is it really worth it? We have to remember that DCE MRI, that PI-RADS is not a system for diagnosing the causes of PSA. It is meant to be a system that enables the detection of significant cancers that may be causing a raised PSA. And in fact, the PI-RADS version 2 specifically states that the added value of DCE above T2 and diffusion imaging is likely to be modest, but we have noted that there are no prospective trials that have evaluated multiparametric MRI using the PI-RADS 2 scheme with and without DCE MRI. So it's difficult at this stage to kick DCE out from the PI-RADS 2 guidance, and we await research in this area. So here are my take-home points. The anatomical location and the presence of pre-existing disease or biopsy artifacts will determine the performance of DCE MRI in clinical practice. We do not need to worry about the complexities of quantification in clinical practice. Complex analyses have roles. These roles are in validation, drug development, and for something called radiotherapy dose painting by numbers, which we don't really need to worry about. For clinical practice, the use of morphology and of curve shapes is sufficient alone, but analyzed in the framework of the PI-RADS data system. Thank you very much.